like, how do we treat the whole child and not just throw different medications at each part of the elephant and hope that they come together in a way that makes sense.
If your child has a brain-based disorder like ADHD, cognitive impairment, learning disabilities, autism, could ketogenic therapy, a ketogenic diet, be a potential treatment for improving those symptoms? Well, Dr. Tracy Gertler thinks, yeah, it might be. And Dr. Gertler joins me today to talk about this with her vast experience of ketogenic therapy for epilepsy and seeing not just the seizures improve, but all the comorbid conditions, all the associated brain-based disorders also improving. And that's why she wrote the paper about ketogenic diets healing the pediatric brain. So I'm pleased to be joined by Dr. Gertler to talk about all these specifics, and I hope you enjoy it as well. Dr. Tracy Gertler, thank you so much for joining me at Metabolic Mind.
Thanks for having me on, Brett.
I'm really excited to talk about this paper you wrote and your experience of using ketogenic interventions in kids, because it is sort of a unique subset, and not just for epilepsy, but for other mental health conditions. So I'm excited to get into that. But first, before we do, tell us, who you are, so our listeners know a little bit about you before we get started.
Yeah, absolutely. So I'm one of the pediatric neurologists at Ann and Robert H. Lurie Children's Hospital of Chicago. I've been there actually since medical school. I did my medical degree and my graduate degree there. I have a basic science background in electrophysiology and ion channels. And what I do now is I primarily see patients in a neurogenetics clinic, and then focus also on kind of knowing the depths and intricacies of their genetic condition and looking at all the tools that we have to help them be their best and achieve what they and their families want to achieve.
With that as your background, I'm curious how you got acquainted or got introduced to ketogenic therapy in this population.
Yeah, so I came into residency with this precision medicine wave that we are going to do more and more genetic testing and use that to identify exactly the cause of early onset epilepsy, developmental delay, and with the advent of gene therapy and gene specific medications, even targeting these channelopathies, we are going to identify the best treatment for these kids. And while we still think that's really important, there are a lot of things that we can diagnose, but we don't have the medicine for yet. There are also a lot of things that we can diagnose as epilepsy, but can't identify the gene-specific cause. So I was lucky enough to do my training at Lurie, where we have one of the biggest ketogenic diet centers in the country. And it was started by Robin Blackford over 10 years ago and then has just grown. So now we have 4 dietitians within our neurology division. And over 350 patients who come through the hospital in some form of ketogenic therapy. And so all the way from being a med student to a resident to an attending, we've treated a whole range of kids, primarily with epilepsy, with the ketogenic diet. And I've seen firsthand, the kids who've tried many, many medications, none of them work. And then we go to the ketogenic diet and we're able to achieve seizure remission, seizure freedom. Had the experience of meeting with families, and I'm like, this is great, the seizures are gone. And they're like, yeah, but also my child now sleeps and they're now talking in ways that they've never expressed themselves before. And so that's been always a really interesting footnote to observe. And part of our work going forward is we should pay attention to all these other things that families are so excited about. And, do we really have to wait until kids fail many, many medications and have gone through years and years of not controlling seizures to offer the ketogenic diet, or can we bring it in much earlier to the conversation?
Yeah, so much to talk about there, but what an amazing experience to be introduced to ketogenic therapy, ketogenic diets as a medical student, and just build on that experience all the way to now as an attending. Really fortunate and unique experience. But I really like how you're emphasizing the other impacts, right? So when someone has epilepsy, it's not like they have seizures and that's it, and everything else is sort of absolutely perfect, right? You wrote in this paper bringing nutritional ketosis to the table as an option for healing the pediatric brain. In that paper, you wrote about sort of the comorbid conditions, whether it's ADHD or whether it's autism or other diagnoses that come with epilepsy, and seeing that those can improve with ketogenic diet. So tell us a little bit about that, sort of the other stuff, not just seizures, but the other things that improve.
Yeah, I think what's wonderful is that we have so much experience with kids and epilepsy, but I do really think that's a springboard for us to start to explore how else can we optimize brain function, because epilepsy is just one syndrome that can manifest when things are not going well. But we do know there's high comorbidity with, as you mentioned, ADHD, autism, intellectual disability. And so when I meet with families with kids with different neurodevelopmental syndromes, we talk about, like, what are your goals for your child? What are the things that you find affect your day to day the most? And even in children who are still having seizures, it's often not the seizures. It's often my child doesn't sleep at all. Every time my child is in a class, they, can make it through an hour or two, and then their emotions are all over the place and they need extra attention and they need to step out. And so they can't participate, or they can't focus. Or, I'm seeing you for seizures, but I'm also seeing a psychiatrist and they want me to start an antipsychotic. And my child has other medical issues and they want me to start other medications. And now I'm on 4 drugs with different side effects. And this seems crazy. How do I balance all of these things? So part of it is, like, how do we treat the whole child and not just throw different medications at each part of the elephant and hope that they come together in a way that makes sense.
Yeah, I mean, that's such an important point. Here's a medication for your seizure. Here's a medication for your ADD. Here's a medication for your sleep. Here's and all these medications piling on top. What are the side effects doing? So, and let's talk about that. I mean, the side effects to anti-epileptics, not only do they not necessarily help some of the comorbid conditions, like you said, but they may even be making them worse. Isn't that the case?
It definitely happens. And for each child, with each new medication, we think about a risk benefit ratio. So, what benefits will this medication offer, but what risks do we have to consider? And when we choose the medication, we try to choose the one with the best ratio. I think that the diet as another option. So, what are the risks and benefits of the diet? Like, how much, how hard is it going to be for your family to change food? What does food mean to your family? Do you have the social infrastructure to support a major change in diet or not? And those are important considerations too. But also to say, we often use the diet alongside medications. So I think of it more as like another tool in our armamentarium rather than a replacement for it.
Yeah. Yeah. That makes a lot of sense as like an add-on treatment to medications, or maybe instead of adding the 4th or 5th medication at that point, potentially replacing future medications. But it can be used in any of those ways, it seems like, and you probably have experience doing it in all sorts of different ways. But you brought up a really interesting point about the family's ability to make the change. And since we're talking about a pediatric population, it's not just the patient, it's the whole family. And it's very different than saying, here's a pill, take it once a day, take it twice a day. That's easy. Although even that, they're probably not 100% of taking the pills, right? And that's easy. So what's going to happen with the diet? So I'm sure that's got to be a barrier to a lot of people saying, just like, no, we can't do this. This isn't going to work, or we tried and it's not working. So tell us about sort of the support and the structure and what's really needed to achieve success for this in a pediatric population.
Yeah, so this is where it becomes so important to have a team, and a team that's talking all the time. So, as I mentioned, we're lucky to have a dietitian who meets with that family and is very knowledgeable in the ketogenic diet. We also often have an APN who can follow labs and go back and forth with the family about some of the side effects that may come up early or later, like constipation is fairly common. But even things like how do I get school lunch in the cafeteria versus bring it? Or my child is used to eating a Lunchable. How can we replace that? We love to have kids build their own bento box equivalent so that they're, it can be part of the lunch table conversation. We also have social workers who join the conversation sometimes and, help us figure out how we can equip a family to succeed. But one of the things that drew me into pediatrics was, you know, everybody wants this child to succeed. So even parents who sometimes neglect their own health see the future in their child and this capacity to add something different to the world and the chance to, if we course correct early in life, we can set up this child for success. So it really is an opportunity. And often we hear, yeah, we were skeptical. We didn't want to do this, but now the whole family is on board and we eat more guacamole or whatever it is that they're willing to adapt and become part of the conversation.
Yeah, I love that discussion that, look, if you help a 50, 60, 70-year-old, you're still really helping them and you can change their life. But 5, 10, 15-year-old, you are changing, decades and decades, the whole course of their life. And if the family can improve their health along the way, I mean, that's just such a bonus. But I want to go back to what you said earlier about that the ketogenic diet may be not as specific of a treatment. And I love your background, like very gene specific. Let's find the one gene, see if we can treat that gene, sort of the one mechanism, one treatment, which is definitely a mentality in medicine. But then a ketogenic diet is kind of the exact opposite of that, the anti of that, because it really is sort of multifactorial. And it can treat the seizures. It can treat the mood disorders. It can treat the hyperactivity. It can treat the metabolic dysfunction. And it almost seems kind of too broad, right? And I wonder if that's a barrier for some clinicians to adopt it, if they're sort of focused on the one problem, one treatment, very pinpoint, and this is just, no, this is too broad, it can't work. Do you see that as a barrier for adoption?
I almost see it as a mental barrier rather than a treatment barrier sometimes, because I do think we run the risk of having people say, oh, you just think keto is a solution for everyone. Should we all be on keto? Well, some of us might think that. I do think there is a counter argument to that. And that's what I tried to illustrate in the paper with this diagram of lots of hands representing different diagnoses reaching into this lunch bag where there's a different assortment of mechanisms. So, maybe one child needs to optimize their mitochondrial bioenergetics because they have a deficiency in one of the complexes of the electron transport chain. Or maybe another child needs to optimize the amount of GABA and glutamate and the balance of those two things in order to control seizures. Maybe somebody else needs to improve dopamine regulation to support emotions and reward behaviors. But I think that ketogenic diet is a chance to reboot the brain in ways that we sometimes understand, but sometimes don't. And I'm not sure we know yet, which of those hands representing depression or representing ADHD needs to grab a hold of which mechanisms. But I think by offering up the ketogenic diet, we are changing the game. We're saying, okay, we're going to help the brain work more efficiently in these different regions. At least we know for other kids like you, this has been beneficial. Let's try. And going back to that risk benefit ratio, we're often talking about the side effects of all of these medications, like overwhelming sedation and having trouble participating in therapies in school. Or we're talking about needing such frequent lab work or having breakthrough seizures where you're in the hospital often and not able to go to birthday parties. So at that point, the diet offers such benefits that I tell families, look, if you are willing to try for 3 to 4 months, I think you'll know. And if after 3 to 4 months we see nothing, no benefit, you can go back to goldfish or whatever it is that you gave up in order to try this with me. But if you're willing to, put in the work, I think you'll know. And we've had kids even who say, like, I feel awesome. I'm never stopping. They recognize the difference in themselves. And If a child feels great, if their parent sees the difference, then they're sold. So they don't want to go back to anything. So
Yeah, and I like how you phrase it as 3 to 4 months because, we do hear these amazing, case reports or anecdotal reports of people seeing changes immediately, like within days, within weeks, and then when we see those, sometimes we set our expectations based on those, and so people say like, "Oh, I've been on it for a week and nothing's changed, so it's probably not going to work." But I think it's great to get that perspective that for most people, it actually is going to take longer. So a true experiment is 3 to 4 weeks. I really like how, or sorry, 3 to 4 months. So I really like how you said that.
we see
Oh,
different benefits, actually, if I can
yeah,
interrupt.
yeah, please.
We see different benefits at different time points. And so, for kids with epilepsy, we sometimes see seizure control early, but then they go on to have the speech benefit or the cognitive boost a little bit later. And then 3 to 4 months down, I hear that the sleep has gotten better and that their emotions are more stable throughout the day. So I think it can be a longer timeline. And sometimes we make mistakes in the beginning about what we can eat or not eat, and it takes a little time to iron out the diet too. So I think we get both.
Fellow mental health clinicians and healthcare providers, you now have access to a suite of free CME lectures on metabolic psychiatry and metabolic health. Each of these CME sessions provide insight on incorporating metabolic therapies for mental illnesses into your practice. These CME sessions are approved for AMA Category 1 credits, CNE nursing credit hours, and continuing education credit for psychologists. And they're completely free of charge on mycme.com. Now back to the video. One other thing I wanted to talk about, though, is the unique circumstance of just dealing with a pediatric population and just saying that word as if it's one thing, right? Whether you treat a 30, 40, 50, 60-year-old, it's all pretty similar. But a 2-year-old, an 8-year-old, a 15-year-old, completely different in their development, in their treatment, in their response, their adherence. So tell us a little bit about, I guess it's kind of a general question, but how it's different to approach, a ketogenic dietary intervention across the spectrum of pediatrics.
Yeah, so there are nuances at every age. So we treat infants with ketogenic diet, and that can sometimes involve adjusting breast milk, adding a ketogenic formula, adjusting a tube feed even, because we know that for some of these early onset epilepsies, even providing a ketogenic diet in infancy can make a big difference. I have a lot of 2 to 4 year olds, so preschoolers, toddlers, who I see where we're just making the diagnosis of a neurodevelopmental syndrome, and it may or may not involve seizures. So girls with Rett present around that age, and many other genes that are just less well known. And that offers different challenges. So now some of these kids are walking around and grabbing their own things from the cabinet or going to birthday parties and wanting, the birthday cake, the popcorn, everything else that's on the table. How can we help them find solutions that work for them? But also, social development is so important at that age. So the last thing we want to do is block them from interacting with their peers. And obviously, that's not what their parents want either. But at that age, at least their parents control what they eat. As they get a little bit older, we start talking more to schools also. How can we work with you at school? What other activities does your child want to participate in? I have a patient who was connected to tube feeds 24 hours a day because it was thought that she needed it to maintain her blood sugar. And she does not have seizures, but her parents felt that she had hit a developmental plateau and perhaps even regressed. And we knew that other children with her genetic condition had used the ketogenic diet to help primarily with seizure control. And we had a very honest discussion of, okay, this is what we know about the diet. This is what we don't in terms of seizures, but also in terms of cognition, sleep, these expressive speech, these other potential benefits. Also, this is what we know about the ketogenic diet, and hypoglycemia, and causes of hypoglycemia and insulin resistance. So what we did was we brought her into the hospital. We slowly converted her to a ketogenic diet and formula, and checking in with her very closely in the beginning and then spacing out those appointments. So now we're a couple of months out. She's been able to decrease the amount of time that she is connected to a tube feed. So she's been able to go swimming for the first time, and it turns out she loves the water. She's been able to ride an adaptive bicycle, which is something that she really couldn't do before because she didn't have the motor skills. And she's started speaking. Her parents sent me a video of her saying, "Mom, mom, mom, mom," that she wasn't doing before she changed formulas. So it's these, anecdotal stories that make us start to question when we offer the diet, how we offer the diet. And really, there are so many forms in which we can offer the diet. So, what are these medical comorbidities that have, pushed us away from the diet before? Can we overcome them? Can we find a way to change your form of ketogenic therapy so that it fits your needs?
Yeah. Wow. Such a powerful example. Just those, you might think, someone might think they're little things like swimming or riding a bike, but when a kid has never been able to do that before, and now they are, and they just love it, and it changes their life and their family's life. Such a powerful example. But so you mentioned about how to adapt the ketogenic diet for each individual. So when it comes to pediatric epilepsy, we often hear about the 4-to-1 ketogenic diet. Very low protein, very low carb, very high fat ketogenic diet. But for what most adults walking around following a ketogenic diet, very different, more like a 1.5-to-1 or 2-to-1 type of ketogenic diet. So do you pay attention to those types of ratios, and is there one you shoot for, and how do you approach that?
So, in a lot of kids where either their epilepsy is relatively well controlled or seizures are not our primary endpoint, we're going for changes in speech, intellectual development, motor function, emotional regulation, other comorbidities. We think about starting more at a modified Atkins diet, so a lower ratio. And that gives us opportunities in a couple different ways. So that means we start the diet at home instead of bringing the child into the hospital for several days. That means that we have them count carbs and try to stay under a certain amount rather than weighing all of their food on a gram scale. Means we can, offset some carbs with things like MCT oil so that can allow them to have some of those treats at a birthday party or something that their family cherishes as a tradition. It gives us way more flexibility. So when we present the idea to parents in the beginning and they get very nervous about stories they've heard, we say, well, like, tell us more what your family does on an average day or weekend. What are things that matter to you? Because we want to make this work for you. And it may not be that you need a high level of ketosis. You may not need a BHB of 3 or 4 to see improvement. We may be able to get you to a much lower level, or even just stabilize glucose, and you may see a huge change in your child. So I think it's important to say, we don't advocate that very, very strict plan for everybody. There's a lot of leeway and a lot of in between and personalization that goes on.
Yeah, so when you have to address some of the concerns and the stories that the parents have heard. What are some of those? What are some of their main concerns?
So growth is a big one. Is my child not going to grow as tall because they're not eating the right foods? And, we follow that very closely in terms of working with the dietitian. Some parents have heard about the change in lipid profile. Is my child going to have a heart attack because their LDL is now this high? Or, I was listening to a bunch of podcasts about keto for me, and now does my child have to worry about these same things? Bone health comes up. They often don't know as much about the things that we worry about, more like constipation, reflux, kidney stones. But these are all things that we can anticipate, that we can help address if they come up. So none of these are insurmountable. this is why we prefer that they do it with the dietitian and the team rather than just starting it on their own and kind of winging it. But
Is it fair to say that basically all of those all of those concerns are much less common on a modified Atkins diet than they are compared to the 4-to-1 ketogenic diet?
they are less common for sure. There are a few absolute contraindications to the ketogenic diet in children that we have to be a little bit careful about. For example, if a child has a genetic primary carnitine deficiency where they're unable to shuttle, those fats into the mitochondria where they need to be in order to produce energy, we have to know that. So I do think it's important to, have all your ducks in a row, do the necessary workup, understand as much as you can about a child going in. But again, that's part of why we have different specialists and a team approach to figuring out how we can help somebody.
Yeah, and that is a unique circumstance for kids, because by the time you're an adult, you're pretty much going to know if you have one of those fat metabolizing defects that is going to keep you from being able to follow a ketogenic diet. But for a 2, 3, 4-year-old, you may not know. So I think that's a really good point. So if somebody, is at a facility without much experience with ketogenic diets, and but they say, hey, I've heard about this and I think I want to try it. Can we try it? Yeah. What kind of advice can you give in that circumstance? Because, you have the benefit of being at one of the foremost, experience centers in the country, if not the world, but not everybody has that benefit. So what kind of advice could you give to parents and to families?
Yeah, I think it's so important to get all your information. So I think if you need to do, a one-time consult with somebody at an academic center to understand all the risks and benefits, make sure you've gotten the necessary testing, and then go back to another place. Like I'm always happy to work with neurologists and other places. I think because I've seen kids with rare genetic syndromes who come visit me and then go back and live, you know, a couple hours away. Sometimes we do work as a team with other providers, but kind of figuring out that plan from the beginning, because the beginning is the trickiest. And, it is an unfortunate reality that genetic testing is still hard to access for many families early on. But I think it's so important. So we are, always happy to offer consults. I'm always happy to work with other practicing physicians of other facilities. It's a small world, so I reach out to other facilities when I have a patient who I'm trying to get into a clinical trial somewhere else. So I'm always open, but get all your information, look around, know all of your options, because like I said, there is a whole lifetime to consider. So getting it right early is so important.
Yeah, well said. Well, let me circle back now to the paper that I brought up. So, bringing nutritional ketosis to the table as an option for healing the pediatric brain. So, healing the pediatric brain. First, I just love that phrase because it shows how it's so multifactorial. But bringing it to the table as an option. So, where do you think we are in that progress, and what do you think has to happen to allow this to be a more of a early discussion, like you said, not waiting for 3 medications to fail, or addressing the comorbidities early on with this type of treatment? So where do you think we are, and what do we have to do to progress?
Yeah, so I think part of it is awareness. I think your podcast is such a big piece of that, but just letting people know that this is even a choice. Within my institution, we have a well-established program for epilepsy, but I'm building a neuroketo clinic essentially so that we can make this an option for other kids. And we're exploring some areas where we know there's a signal that keto can be helpful. So for migraines, we know the ketogenic diet can be very useful. There is at least one trial that shows that in multiple sclerosis, the ketogenic diet is beneficial in terms of improving functionality and quality of life. Not to say that we're going to replace immunosuppression, but for a family who's tried everything, I want something more, I want something different. Can we add this? Same thing for, a lot of these comorbid neuropsychiatric conditions, because I think the energy and momentum is building so much in metabolic psychiatry, and the comorbidity rate is so high that I think we have an obligation to say, that there are other choices. Let's lay everything out in front of you and see what we can do, because at the end of the day, everyone wants to make the child feel better and succeed. So, I think getting everybody on the same team to say, look, I'm not pitting a medication against a diet intervention against a surgery. We're saying these are all options and we're going to find the best combination, order of operations tweak to get your child to where they need to be. And I don't care which solution works, but you should know of all of these choices.
Yeah, and I really like how you said you're opening the neurology clinic. It doesn't have to be the seizure clinic, but the neurology clinic. And you can sort of see like how metabolic psychiatry and epilepsy, and now we're sort of meeting in the middle, right? Is it, a treatment for schizophrenia, bipolar disorder, and major depression? Well, yes, but then you also see OCD, anxiety, ADHD, and these other conditions improve. So kind of going that direction. And then is it a treatment for epilepsy? Yes, but then you also see, like you've said so well, the ADHD, the cognitive impairments, and so many of the other comorbidities and the migraines, et cetera. So meeting in the middle, like starting with sort of the extremes, I guess you can say, but then realizing brain health is brain health. And it can impact so many different things. So I really like the progress you're making there. And do you think that's going to be a trend, that we're going to see other places that have an epilepsy center start to use ketogenic therapies for a broader range of conditions?
I think the cool thing is that maybe epilepsy brought the resources and the enthusiasm, and we established some protocols, and everybody is safe and comfortable with it. When a child gets admitted, we know how to not give them IV fluids that are loaded with sugar, for example. Um, but so now that we have those resources, yeah, I think I'm having this conversation, within my own division and then with other divisions more and more often, talking to um, our our wellness clinic about obesity, and talking to our oncology division about kids with brain tumors, and could this be another option? Because you know, if we have a vested interest in the ketogenic diet, maybe I know about those data, but maybe that hasn't been as obvious for other people or hasn't come across their PubMed feed. So if I can spread awareness and also provide that initial consult to say, okay, like I can manage the day to day of this, and this awesome dietitian 2 doors down can help your family figure out the recipes that will work for them. All you need to do is you keep treating the cancer, and we'll go back and forth as many times as we need to, but look what else we can offer this family. How cool.
Yeah, what an amazing resource. It's really encouraging to hear the opportunities like that arising, because it really could change so many lives. Well, this has been a wonderful discussion. Thank you so much for joining me and sharing your experience and all your wisdom. If people wanted to learn more about you and the work you're doing and follow you, where can we direct them to go?
Yeah, so we're working on revising the Lurie Children's website to include more information about this neurology keto clinic. But for now, I'm most accessible through my faculty webpage at Lurie, or my email at Lurie.
Great. I really look forward to that. Well, thank you again. I really appreciate it.
Thanks for having me, Brett.